Thank you, Dr. Kishore, for involving me in this wonderful IC. And sorry, I'm late. I was caught up in another session parallelly. Is my slide visible?
Yes.
Okay, so I'll just get started. So actually, this was Dr. Madhukar Reddy's talk, but he had to be away. So I'm taking his topic of collagen cross-linking, a current update. So cross-linking is something we have actually borrowed from our dental colleagues, just like phacoemulsification also was kind of inspired from dentist procedure. They use ultraviolet light routinely to fix dental fillings and harden them. And essentially, that's a similar kind of thing that we are doing in the cornea. We are instilling a dye, photosensitizing dye into the cornea, and then we are applying UV light of a particular wavelength to cause a kind of a chemical reaction and collagen bonds, covalent bonds between collagen fibers of the anterior stroma. So what are the indications? Essentially, the main indication is, of course, ectasia. In keratoconus, we typically like to do it in progressive keratoconus, but there is increasing argument for doing it as a primary procedure, especially if you have young patients, female patients who are likely to have future pregnancies or have thyroid, or even in older patients if you are seeing a progression, clear-cut evidence of progression. Post-LASIK ectasias we know are known to progress rapidly. So as soon as you see a post-LASIK ectasia, it is an indication for cross-linking. Peripheral ectasias are a relative indications because cross-linking is not as effective. So if you have like a pellucid, you may not be able to effectively stop it with cross-linking, but some people have shown success with cross-linking. So you could try them as a first measure. And additional indications for which people are using cross-linking is microbial keratitis, refractory microbial keratitis. Essentially, the UV rays are supposed to kill microbes, and it has shown some benefit in certain subset of patients. If people have also combined it with refractive corneal procedures like LASIK and PRK in borderline cases, but the evidence is not very strong for these. And also for bullous keratopathy to prevent the recurrent bullae formation, it has been used with some success. So there are mainly three elements when we are talking about collagen cross-linking. One is the UV light, one is oxygen, and riboflavin. People just often talk about UV light and riboflavin, but forget about oxygen. And without oxygen, that reaction cannot take place. You need oxygen for cross-linking to work. Okay, and that is why many of the procedures like trans-epithelial cross-linking and all don't work, because oxygen doesn't reach the site where you want the cross-linking. Several protocols have been described. The traditional protocol of cross-linking, which was originally started, was the Dresden protocol or the standard protocol. But several modifications have come, like the accelerated. We have modifications for thin cornea cross-linking, trans-epithelial cross-linking. When you combine cross-linking with an excimer procedure, and pulse cross-linking also is available. So how do you navigate this sea of protocols that are available, and how do you choose the right one for your particular patient? So the Dresden protocol was first described by Wolansak et al., in which they do a epithelial removal, apply 0.1% of riboflavin for 30 minutes, followed by irradiation with UVA of the fixed wavelength for another 30 minutes. The power of the cross-linking UV is 3 milliwatts per centimeter square, which comes to 5.4 joules per centimeter square. So we remove about 7 millimeters or 7 to 8 millimeters of the cornea, depending on the size of the cone. And this is how it's done. Okay, so every time before you do the procedure, you must make sure that you are calibrating the ultraviolet light. Then you scrape off the epithelium. You can use alcohol or you can use some sort of a blade. And then you instill riboflavin. Earlier, the riboflavin included dextran, but nowadays we are using riboflavin with HPMC. The advantage is that dextran causes the cornea to become thinner, and you don't want it to become thinner in an already thin cornea, because that will also give you the possibility of irradiating the endothelium, which you don't want. And final step is, of course, UV irradiation. You have to make sure that the beam is at all times centered properly on the cornea, depending on the site of your ectasia and the site of your epithelial defect. So this is an important rule that we must remember, the Bunsen-Roscoe law of reciprocity. Basically, the same photochemical effect can be achieved by reducing the irradiation interval if you increase the energy, and vice versa. Okay, so basically, theoretically, you can use 3 milliwatts for 30 minutes, or you can use 30 milliwatts for 3 minutes. Although practically it doesn't exactly apply, but essentially that's what this law states, so that your net exposure is 5.4 joules per centimeter square. So these are the various protocols which can be used. So the traditional protocol is 3 milliwatts for 30 minutes, but the accelerated protocols are basically based on this Bunsen-Roscoe law. So you can use 10 milliwatts for 9 minutes, 5 milliwatts for 18 minutes, and 3 milliwatts for 30 milliwatts for 3 minutes. And essentially all of these will theoretically give you the same result, but in practical experience, we see that when you increase the energy and reduce the duration, then sometimes the CXL effect is not as good. And that mainly is because, probably because of the oxygen. So there have been several studies which have compared these different protocols, and it is clearly shown that the resident protocol is the most effective, and you have a decreasing effect as you reduce the duration. So probably a good balance would be the 9 milliwatt for 10 minutes if you want to kind of save time, but still get a fairly good amount of UV irradiation and cross-linking effect. So that's the one which I would recommend if you want to do accelerated cross-linking. And essentially, you should do this in children, in adults only. In children, if you do accelerated cross-linking, you know that the longevity and effectiveness is lesser in children. So you probably want to give them a full Dresden protocol, unless there's some other indication that child may not cooperate or something like that, that you need to hurry up the procedure. So there have been several studies which have shown that the cross-linking till 9 milliwatt works very well, and beyond that, the effect is not very good. And this was a nice study from the Narayan group in India. So there is another modified accelerated protocol which has shown 18 milliwatts into 7 minutes instead of 5 minutes. And they have shown that even though you're giving that 7.45 joules per centimeter square instead of the 5.4, which should be traditionally given, the demarcation line is actually similar to what you would get for a 5 minute. So if you want to use a shorter duration with 18 milliwatt, instead of 5 minutes, you can use a 7 minute and get an equally good effect, but save that additional 3 minutes instead of using 10 minutes with 9 milliwatts. Epithelial on cross-linking was in vogue some time back, but I think essentially most people have now given it up because it doesn't work as well. And this is because the penetration is not very good, both of the riboflavin and the oxygen through an intact epithelium. So if you have to do an epithelium on cross-linking, you had to use stronger concentration of riboflavin, and use the riboflavin used to be also having additional agents like BAK and EDTA, which enhance the penetration of riboflavin. So that way you are overcoming the barrier effect of the epithelium, but still the second problem of oxygen crossing the epithelium was always there. And that is why at least I have stopped doing epithelial non-cross-linking completely. Irontophoresis is another method of epithelium on cross-linking in which you use an electrical charge to facilitate the flow of riboflavin through the epithelium, and that works very well actually. Through the intact epithelium, the riboflavin reaches, but again the same problem, oxygen doesn't reach as well, and that is why this also is not as effective as epi-off cross-linking, which is the standard cross-linking. So that's same thing being depicted. And basically what they've shown is that the amount of oxygen that reaches is 1x compared to 10x, which is taken up by the epithelium. So another new recent modification is the use of cross-linking for thinner cornea. So traditionally the limit for cross-linking is 400 microns. And if your cornea is lesser than 400 microns, you would not do it because it would be considered unsafe for the endothelium. So people have stretched that limit and taken it up to about 380 microns, but below 380, one could not do with the standard Dresden protocol. But now studies have shown that you have some alternatives. Earlier, people were trying to use hypotonic riboflavin to thicken the cornea. But the problem with hypotonic riboflavin is that the effect is very short-lived. So you have to either keep instilling it, or you have to, and then also you can't be sure, because the cornea will become thin in between. So you might end up damaging the endothelium, and it's a very unpredictable way. So essentially, this has been given up. People did try use of contact lenses, but again, contact lenses may same problem of oxygen transmissibility was there, as well as the riboflavin was not reaching as well. So the effect in practical applications was not as good as Epithelial crosslinking. People tried adding the shoe like a corneal lenticule, and that of course can work, but then you must realize that that lenticule which you're putting is eventually discarded. So that much of cross-linking effect is lost when you remove that lenticule. You could leave a little residual island at the kind of apex of the cone where the cornea is the thinnest, and you can do the rest of it. That's the Mazota technique. But essentially, the place where you really need most cross-linking is not getting effective cross-linking because of that. The final technique, which I think is here to stay, is that of adapted fluence. And we have to thank Professor Hafezi from Switzerland for telling us about this. Essentially, in this, what we are doing is we are reducing the overall fluence that we are giving. So instead of 5.4, you are giving it a smaller amount, maybe 4 or 3.5, depending on the thickness of the cornea. So basically, you are not changing the UVA power, which may be 3 milliwatt per centimeter square, or say 9, whatever. But you are reducing the duration depending on the thickness. And studies have shown that this gives an equally good effect as a standard cross-linking in a thin cornea, without having an effect on the endothelium and having a good demarcation line, just like you would get in a regular riboflavin. So you are using that same principle, but you're reducing the duration, and essentially you're getting a very good effect. So that I think is the future. And there has recently been a paper which has come out from Dr. Hafezi's group, which has kind of shown this in a large series of patients, and they are able to do this for corneas sub 300 microns with wonderful effects, almost 265 microns if I'm not mistaken. So hypotonic riboflavin was basically riboflavin in sodium chloride, 0.9%, with osmolarity of 310 milliosmoles per liter, epi of, and basically you have to initially instill the hypotonic riboflavin and then go for regular riboflavin and then crosslink. But I told you the problems with that. This is the protocol for contact lens assisted crosslinking from Dr. Agarwal's group, and they use specialized contact lenses which are not UV blocking. So some literature is there in evidence of this, but there's also literature showing that it doesn't work as well. This is the picture showing that epithelial island being left behind at the thinnest point, but again, it has questionable efficacy. So adapted fluence is what I like to use. A nice online calculator is available, which has been made by the Narayan Netrale group, and that can be used, or you can refer the original paper from Farhad Hafezi's group. So this is the online calculator which is available, called the Next Calculator. And you just have to input the patient's preoperative thickness, and it will tell you how much time for 3 milliwatts, 9 milliwatts, etc. So it becomes very easy essentially. So people have combined it with topographic guided cross-linking as well, and it certainly has a role. There are two protocols which are available. One is the Athens protocol, popularized by Kanalopoulos et al., and there is also the Cretan protocol. Cretan protocol is basically like a modified transepithelial PTK. Now, this does work, but the rationale is basically you're not trying to remove the refractive error, you're just trying to regularize the cornea so that you can improve the uncorrected and best corrected visual acuity. There has been some controversy about the role of mitomycin C, but initially people were using it, but recent papers have shown that mitomycin C actually increases the haze. So I have now stopped using mitomycin C when I combine these procedures. So Athens protocol, basically you do a maximum of 50 microns of ablation. So you do a topography guided PRK and make sure that the bed is about 400 microns. You can go below 400, but then you have to do an adapted fluence like I showed you in the previous talk. The treatment protocol is basically a PTK, in which when you're doing the PTK, you must remember that the epithelium is thinnest at the apex of the cone. So at that apex of the cone, you're shaving a little bit of the stroma to regularize the cone, and then you're doing a cross-linking. So just ablate about 10-15 microns of the stroma at the cone, and that is known to give a wonderful effect. The extra procedures, the evidence is very weak. I think it more makes you feel like you're adding some strengthening to the cornea, but one really doesn't know whether adding a small dose of cross-linking to a PRK or a LASIK or SMILE is really going to give you much, and we need more literature for this. I'll just take a few seconds more. People have also tried using pulsed light, in which you don't give UV light throughout, but give it in pulses. And this has shown to have some effect. But again, you need a specialized machine for that. And not enough studies are available to show whether it really helps. Customized cross-linking, we use a specialized cross-linking machine in which you basically Avogadro 2, in which you are giving more cross-linking at the apex of the cone and lesser as you go peripherally from the cone. So at the inner circle is 10 joules per centimeter square, and then a middle circle of 7.5 and an outer circle of 5.4. So advantage here is that you induce more flattening at the apex of the cone, so it becomes flatter there, and thereby you're also doing some shape correction in addition to just cross-linking, and that might actually give you a refractive effect as well. So you're doing it in 3 kind of steps. And finally, people have combined it with keratitis with in refractory keratitis for treatment of microbial keratitis. The studies are mixed. It does have to seem to have some effect, but doesn't work for all cross-linkings. Variety of riboflavin solutions are available, for epithelium off and epithelium on, but essentially I think most of us are now using isotonic riboflavins. So this is how the evidence is stacked up. Only the ones on the top right are the ones that really have good evidence. And for everything else, I think the evidence is weak, and we need more evidence before we can kind of adapt this. And this finally, I'll end with this. Now, a new machine has come in which you can cross-link on the slit lamp itself. Again, invented by Dr. Hafezi, and I think this might make it a procedure which is not just limited to people who have operation theaters. You can do it even in secondary centers which have just a slit lamp, and especially for people who are in very peripheral areas, this might be a good solution. So cross-linking, longer duration protocols are definitely more effective. It can be combined with surface ablation or intracorneal ring segments in selected cases. It may be useful for microbial keratitis, but we need more evidence. Adapted fluence is something which is exciting for thinner corneas, and slit lamp cross-linking might increase access and reduce the cost of this procedure. Thank you. Sorry for overshooting a little bit.
Thank you, sir. Sir, are you going to continue for the for other talk as well? That is yours.
Yes.
Okay, so maybe start the timer.
Yeah. Shall I go on, Dr. Gantishore? Or?
You can go on.
Okay, sir, we'll start the timer as well. Thank you.
Is my presentation visible?
Yes.
Yes, sir.
All right. So my next talk is on the role of keratoplasty in ectasia. So this is the decision tree that I follow when I'm planning the management of ectasia. So if it is an ectasia alone, then you have to see how is the thickness of the cornea. If it is very thin cornea, then probably a pre-desmetic DALC or a penetrating keratoplasty might be better. So extreme ectasias. But if the thickness is quite good, then of course you can go for a traditional big bubble or a manual desmetic DALC, in which you can try to go down to the desmes level. Because if you have a very thin cornea, sometimes getting down to the desmes level and attempting a big bubble may be dangerous. If you have an ectasia along with a scar, a deep scar, or a evidence of old hydrops like a scar in the desmes membrane, then such cases doing a desmetic DALC is risky. So one could do a penetrating keratoplasty or a mushroom kind of a keratoplasty, One can, of course, attempt a DALC also if the scar is not very significant, but one must remember that you may have a suboptimal visual outcome. And again, if you have a persistent hydrops and the cornea is edematous in spite of everything, and there's a large tear in the Duas layer, then in such cases, there's no choice, but you have to do a penetrating keratoplasty. So when we talk about advanced keratoconus, it's basically when the cone is either too thin or the cornea is too ectatic, or if the area of ectasia is too large in terms of the diameter. Corneal hydrops is a common occurrence, and persistence of edema is indicated by indicative of a desmus discontinuity or a severe endothelial injury. So why is an advanced keratoconus different? There's either too little stroma, so less working space for lamellar procedures. The desmus membrane is weakened because of extreme stretching, so it can rupture easily on touch. Desmus membrane and the Duas layer. There may be old hydrops or a deep scar. Again, high chance of desmus perforation during a deep lamellar dissection. And the cones may extend to the limbus, may be very peripheral, necessitating large or eccentric grafts, which in case of a penetrating keratoplasty will be a risk factor for rejection. It's important to assess these corneas carefully on the slit clamp and with diagnostic procedures to look at the size and location of the cone. Specifically look for deep scars near the desmus membrane, which may be a marker of old hydrops, or any irregularity of the desmus membrane, proximity to the limbus, and the severity of thinning. OCT is a very, very useful tool, especially in the management of keratoconus, to look at several aspects. One is to look at the thinnest pachymetry, because it gives you a thick pachymetry map as well. Look at the location of the thinning, the extent of thinning. Look at the depth of the disease, and look for deep scars and desmus membrane irregularity. So this is just some OCT images in which you can see here on the pachymetry map, you can see how widespread and how thin the cornea is. In this case, the thinnest point is 183 microns, which is fairly thin. And again, a large part of that 183 would also be epithelium. So, introducing a needle or a cannula might be a little tricky in this kind of a situation. Measure the actual stromal thickness. You can see in this case, the epithelium is quite irregularly thickened, and that might give you a false sense of security when you're doing the procedure. These are all images showing old hydrops. You can see deep scar in the bottom left image, and all three other images show irregularity in the desmus membrane, indicating that there's been a hydrops. And in such a case, if you try to do a desmetic dissection for DALC, you will end up with a perforation. So if you don't have any of these problems, and of course, DALC is the ideal procedure of choice, and the most popular procedure of deep lamellar keratoplasty is a big bubble DALC, in which essentially you're introducing a big bubble of air in the deep stroma, and that kind of separates the stroma from the pre-desmetic Duas layer. And once you've done that, you're essentially dissecting out the stroma anterior to that in a kind of a pie-shaped fashion to kind of show the bare Duas layer, which appears as a nice clean layer, like is shown in the video on the right. But it may not be possible in very extreme ectasias because of the paucity of stroma. So then you may have to think of additional procedures. I often do a manual DALC in these extreme corneas because in my hands that is more predictable, and you have a safer outcome. So you have to, in the procedure that I follow, which is called the groove and peel technique, I do a partial thickness definition depending on the extent of the cone. So here you can see I've marked out the extent of the cone with the gentian violet marker. And then you do a scissor dissection. So you go in with a closed blade and then you open it, and you kind of just go all around. And then you keep going in a deeper circumferential dissection underneath the trephination mark, like is shown here. And as you keep going, spiraling deeper and deeper, at some point, you will find the shiny pre-desmetic Duas layer. And at this point, you can actually hold that central island of desmus membrane, of stroma, and peel it off the Duas layer in the desmus membrane. So basically, you're using traction forces to do the peeling in the central cornea, and dissection is all done in the peripheral cornea, as you could see in the video. And because you're using traction forces which are distributed over a large surface area, all these fine attachments between the stroma and the Duas layer are easily separated, as you can see in this particular video. And you can just peel the whole thing off and open up this potential space very nicely. Once you've done that, you take the stromal button and then peel the descemes membrane off it from the endothelium side, like was shown here, and then you put the button in place and suture it. That's quite simple. If you have a very young donor, sometimes the peeling the descemes membrane is not very easy and it may have to be removed piecemeal. So this is just another patient with a keratoglobus kind of a picture. As you can see, the cornea is extremely thin and the stroma is actually having no attachments to the predesmatic layer and just peels off like a LASIK flap. It's okay to leave behind a little bit of stroma if you have a very extreme kind of a ectasia with a very thin cornea, because in such cases, you just don't want to have a perforation. Here's a case in which we have a perforation while we're trying to peel. This was a patient who had an old hydrop. So the learning lesson, never try a descemetic kind of a dissection if you have an attachment of the deep layers to the descemes membrane or the Duas layer. But the good news is, in spite of perforation, you can manage to complete these cases as a lamellar procedure in almost 90% of cases with wonderful outcomes. You can see in this case, the cornea was very clear very soon post-operatively. This is just another representative picture of how clear deep lamellar keratoplasty corneas can look. On just the first postoperative day, you can see the bubble of air is just there. It looks like a penetrating keratoplasty. So you can see we use a large graft, and normally if you would do a penetrating keratoplasty of such a big size, you would end up with a rejection eventually. But here, because it was a DALP, this patient did beautifully well. And rejection is very rare in these cases. So penetrating keratoplasty does have a role. Earlier, people were doing it very often, especially if they are not proficient in DALP. But I think in today's day and age, you are doing a disservice to this patient, and he might come back to you many years later and ask you, why did you do a penetrating procedure? And I've ended up with a failed graft. You should have done a DALP. And if not him, somebody else will tell him that your first surgeon has done a disservice. So in today's day, I think if unless indicated, penetrating keratoplasty should not be done for any ectasias. But it does have a role. If you have central scars, especially those involving the descemes membrane or deeper layers, and if you have old persisting hydrops with continuing edema of the cornea, then you don't really have a choice. So some of the tips when you're doing penetrating keratoplasty in these eyes: collapse the cone. You can use a cautery to actually apply directly over the cone and it can shrink. The advantage of doing that is trephination becomes a lot more controlled. Otherwise, if you have very ectatic cornea, you'll end up trephining eccentrically. Encompass the entire cornea. That's very, very important. If you don't remove the entire diseased cornea, you will have a recurrence of ectasia either in the graft-osed junction or beyond it. Avoid oversizing in ectasias because these are very stretched out corneas. If you just do an oversized cornea, then you may end up with a myopic refractive surprise. You can go with the same size graft or oversize very little, maybe about 0.25. FemtoAssisted grafts are probably a better idea because the endothelium is largely healthy in these eyes and the problem is in the stroma. So if you use a femto, you can go for a mushroom kind of a configuration in which you do more of the anterior layers. So this is one patient of mine who had a very, very bad persisting hydrops. And you can see that there's a big tear in the Duas layer and an extremely hydrated cornea. So in such a case, there's no point doing a DALP. You have to do a penetrating keratoplasty. Now, earlier I didn't know better, but now today I would just do a penetrating keratoplasty in the area of the perforation. In this case, because the whole cornea was so edematous and scarred, I did a large diameter graft, as you will see soon. So it's like a regular PKA, and you can see that the large graft well sutured, and this patient did quite well for many, many years. You can see a very nice clear graft, 2025, but eventually he ended up with a rejection and we had to do a DSEC underneath this graft. This is another very interesting case. Patient came with a large hydrops kind of a picture involving the central and the inferior cornea. So my clinical impression was that this patient probably had a peripheral ectasia, which has then resulted in a hydrops, which is also involved the central cornea. And we kind of, we did a intracameral C3F8 injection in this particular eye to help reduce the hydrops. And then we ended up with this kind of a cornea, which was very scarred in the center and also had some sort of some element of edema also. So you can see that central cornea is quite scarred, involving the deeper layers. And this was involving the Descemet's membrane. So there was no way that a dial could work, and I had to do a penetrating keratoplasty. But I didn't want to do such a large diameter dial because this patient essentially had a pellucid as well in the inferior cornea, which you can see in this image. So I did something different, which was a split mushroom graft, which was done manually. So I did a large diameter anterior stromal trephination, and I essentially dissected the anterior stroma off layer by layer, as you can see in this video. And once the anterior stroma was taken off, a large chunk of it, I decided to do a central endothelial graft within that. So I took a donor cornea, mounted in an artificial anterior chamber, did the dissection like I would do for a DSEC. And then I went back to the recipient cornea and did a small 6 millimeter central trephination like so. So basically I took out that central cornea, which was unhealthy, and took the donor dissected lenticule from the artificial anterior chamber and took a central 6 millimeter graft like this. And then I put the large diameter 9.5 or 10 millimeter graft, anterior lamellar graft on top of this and sutured it. And you can see we got a very good outcome. I had, of course, put an air bubble to keep that endothelial graft in place, but then basically this was like combining an endothelial graft with a large anterior stromal graft. So it was actually the best of both worlds. And this patient has recently come to me and he has 20/20 vision in this eye and is extremely happy and almost 5 years post-op. FemtoAssisted grafts are a very, very useful thing in keratoconus. And here I'm doing a femto deep lamellar keratoplasty. So you can see a mushroom configuration has been done. And you can see that on the right, we got a very good, well-opposed graft. And this patient did very well. So to conclude, surgical intervention is indicated in ectasia when contact lens fitting is not possible or the patient is not tolerating it. Especially if there's a risk of hydrops or there's a pre-existing hydrops or in case of central scars. The choice of keratoplasty will depend on the factors like I mentioned earlier, the extent of thinning, presence of central scars, involvement of deep stroma, etc. Penetrating keratoplasty can be done in some selected indications like long-standing hydrops and central scars. And deep lamellar keratoplasty, although technically challenged, it will eventually result in a wonderful outcome in most of these patients. I've done hundreds in keratoconus with excellent results. And later you can go on and do a correction of any residual error with a surface ablation. Topography guided ablations can be done to give very good unaided as well as best corrected vision in these patients. And you have extremely satisfied patients. Thank you. So I made up for the excess time I took in the previous talk.
Thank you so much.